Good afternoon, everybody. Am I audible?
Yes, ma'am.
Can we start or shall we wait for 5 more minutes? What should we do?
Ma'am, we can start.
Okay. Good afternoon once again. These are your few initial few pediatrics classes, right? This is your first exposure to pediatrics?
Yes, ma'am.
Okay. So what have you learned till now? What were the previous 2 classes?
History taking and physical examination.
Okay. So I would like to make this a little bit interactive so that all of you are not sleeping. So Anjana, can you tell me what is different in history taking? You've learned about history taking in medicine as well, right? So what have you, what is extra or what new things did you take history in pediatrics when you learned about history taking as well as in examination?
We have to ask antenatal details.
Anybody can. Okay, yeah, fine. That is good.
About immunization.
Immunization
of the child.
Very good. Yeah. Then anything else that is not there in adult history? Anybody else can tell me?
Development.
Yeah. Okay. Yeah. Good. Development. Okay. So basically, those 2 or 3 things that we learn extra. Antenatal, natal, and postnatal history you have to ask for, and in addition to that, you have to ask about developmental history and immunization history, as well as nutrition. You have to ask for in medicine also, but maybe not as much as detailed as you have to ask in pediatrics, right? Then somebody else, Nihala, can you tell me in examination? Did you learn about anything extra that you have to look for in pediatrics?
Ma'am, head to foot examination.
Yes, good. Head to foot examination. Anything else?
Then head to foot examination.
Anthropometry.
Anthropometry.
Are you told about anthropometry? What is anthropometry?
Ma'am, head to foot examination എന്നല്ലേ പറഞ്ഞുള്ളൂ. Skin and back.
അത് മാത്രമേ പറഞ്ഞുള്ളൂ. Okay. ശരി. അപ്പോൾ again like history, like in history, in examination also, medicine you have to look at the vital signs. Then and you have the pickle, that is parallel rectus, adellam nokkittu you go to system examination. In pediatrics, in adult medicine also you have to look at the weight and height and all of the patient, but in pediatrics the weight, height, all that have more significance, and that is measured, that is a separate heading called anthropometry. Okay, so that I know you guys are this is totally new to you, so just to നിങ്ങൾക്ക് ഒരു concept കിട്ടാൻ വേണ്ടി ഞാൻ പറഞ്ഞതേ ഉള്ളൂ. So that is what is then special or additional that you look at when you're looking at pediatrics, and one of the things that you are assessing in addition to the general all the general things that you look at whenever a child is brought who is sick is the growth of the child. Okay, so common sense, why is growth so important only in the pediatric age group? Anybody? Somebody can tell me why we are so particular about growth? And yeah, Jeffy, please let me know. Please tell me. Jeffy, you wanted to answer?
Delay.
You said developmental delay. Okay, good. So basically, in the pediatric age group, it is the time when an infant.
Disorders assessing.
Okay. Other development karyana. Similarly for growth. So you know that whenever you are examining or when you are assessing an adult, growth and development does not have much of a role. Why? Because growth and development have already been completed in that adult. So it does not matter whether he's 20, he's 30, or he's 60. All those parameters, we assume that all of them have the same. That growth, if you are talking about weight and all, we have to measure the BMI. But other than that, we are not concerned much about the height. We're not concerned much about the head size of that patient, because all of them, we assume that all that will be a uniform. Okay, that is totally different in our field. That is in pediatrics, growth and development are go hand to hand, because many diseases will be affecting growth. Many, if it is a neurological condition, it might be affecting development. Or because the growth and development is affected in the child, maybe that could have led to the disease per se. Okay, is that clear? That is why we are very concerned about growth. And even if the patient who comes in front of you does not have a disease, or we need to know how the child has to grow normally, if we have to find out if there is anything wrong with the growth of the child. Similarly, for development, only if we know what are the normal methods in which, what is the normal pattern by which the child is going to attain his developmental milestones, only then we will be able to, like he mentioned, Jesse was mentioning about developmental delay. So how do you know there is developmental delay? You need to know what is normal development to see if there is developmental delay. Okay, is that clear? So that is why we are very concerned about growth. So what is growth? What is the definition of growth? Anybody? Abhirami? What is growth? Yeah, Abhirami? Parno.
Ma'am, അറിയില്ല ma'am. Hello? 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 Hello?
I'm sorry, there was a problem, I think, with the net. It got am I audible, Aparna? Anybody? Can you hear me?
Yes,
Yes,
ma'am.
ma'am. Kelka.
So we were talking about growth, alle? Can you see my slide? Visible ano?
Yes, ma'am. Kana.
Talking about what is growth. So growth is defined as increase in size and number of cells. So it either size or both. Both happens when both happens. That is what we call growth. Okay. Whereas development is maturation of function. So even if somebody grows, does not mean that their development is normal. Okay. So when I was talking about this, so can you tell me when growth begins? When does growth begin? So growth begins intrauterine. It is not something that happens after the baby is born. It begins even before that. As soon as the embryo is conceived, growth begins from that phase. Okay, so the factors, what all are the things that can affect growth? That include things like which can happen even before the child is born. Okay. Just give me 2 seconds. I'll just try to connect my laptop once more. Okay, so growth is the things that we need to know. What are the things that affect growth to see if why the child is not growing normally? So those factors are divided as prenatal and postnatal. Okay, so I will just go through that. Aparna, can you just confirm that my slide is visible?
Yes, ma'am. It's visible.
Okay. So we said what is growth. Next is what are the factors affecting growth. So I told you it can be prenatal factors as well as postnatal factors. Prenatal factors can be divided as fetal, placental, or maternal factors, because those are the three things that are at interplay in the antenatal period. And postnatal factors can be genetic or environmental. So what are the factors affecting prenatal growth? What the factors like fetal factors can be? One is the genetic potential. So it is a parental trait that tall parents will have tall children. Again, head size has a familial tendency. So parents who have large head will have children who have large head. Similarly, small. So from whenever you are measuring head circumference for a child, it is either too low or too high. Remember that you also have to measure the head circumference of the mother and the father. Gender. Boys are usually larger than girls or taller than girls as well. And race, growth differs in different races. We know that South Indians are maybe a little shorter generally. This is all general rules, not applicable for, cannot be universally applied. Okay. Then there are fetal growth factors. What are the fetal growth factors which can affect growth? There are factors which have involvement in growth promotion as well as in growth inhibition. The factors which are helpful in growth promotion are insulin-like growth factors, IGF-1 and IGF-2. Then other factors are epidermal growth factor, transforming growth factor alpha, and platelet-derived growth factor. Transforming growth factor beta is a growth inhibitor. Similarly, Mullerian inhibiting substance or anti-Mullerian hormone is a growth inhibitor. Inhibin or activin family of proteins are also involved in growth inhibition. So this is basically, there should be a balance between the promoting factors and the inhibiting factors to have a normal growth factor. Now, what are the other next things? Fetal hormones. What are the hormones that have influence in prenatal growth? This is mainly in the late gestation, that is in the second and third trimester. Insulin and thyroxine are important for accretion, that is increase in cells as well as in differentiation of tissues. Glucocorticoids are the steroid hormones, are required for maturation of organs like lungs, liver and GI tract. Okay, and here you can note that influence of growth hormone in the fetal period, that is in the prenatal period, growth hormone does not have much effect on growth. Okay, so this is something you must have learned in the in your last year physiology, right? So can you tell me in the lung, this we have mentioned about glucocorticoids and lung development, lung maturation. So what happens when there is a preterm delivery? What happens in the lung? What is that called?
Ma'am, ARDS will develop.
ARDS ആണോ? ARDS is acute respiratory distress syndrome. അതാണോ? Acute ഉണ്ടോ? അത് RDS മാത്രമേ ഉള്ളൂ?
RDS.
What happens in RDS? What is the pathophysiology? നിങ്ങൾക്ക് ഇൻട്രസ്റ്റിന് വേണ്ടി പറഞ്ഞേ ഉള്ളൂ. സർഫാക്ടൻ ഡെഫിഷ്യൻസി കാരണം in preterms, when they are born, there is not much of surfactant, because of which they will have severe respiratory distress. And the practical application of the fact that steroids are required, whenever there is a preterm delivery, the mothers are given steroids to induce or to accelerate the lung maturity in the preterm baby before he or she is born. Okay. Next is placental factors. Placenta is essential for nutrition of the factors. So all these things like villus surface area, diffusion distance, capillary dilatation, all these factors will influence fetal nutrition. So when the villus area is increased, diffusion distance should be decreased. There should be well dilated fetal capillaries, and vasculature resistance should be low. What are the maternal factors? Poor nutrition, anemia, recent pregnancy, so multiple pregnancies within a short span of time, high parity, tobacco, drug or alcohol intake in the mother. All these affect fetal growth in an adverse manner. Pregnancy induced hypertension, multiple pregnancies, twins or triplets, chronic systemic diseases or torch infections. What is torch infection? Anybody knows?
Toxoplasma rubella.
Very good. So those are torch, that is not an exclusive thing. It is just a few of the organisms which, if the mother has an infection in the antenatal period, will affect the baby growth, development, etc. in an adverse manner. Okay, so those are the maternal factors. So we finished prenatal factors. Prenatal factors na divide into fetal, placental, and maternal. Now postnatal factors. Again, postnatal gender we have like we told, boys have a greater growth potential than girls. The growth spurt in puberty. What happens in puberty? We'll just go through that as we go on. Puberty, there is a growth spurt. That growth spurt is earlier in girls. So at a particular period in time, girls might be growing faster or earlier, but then ultimate height boys will be there is a more time for pubertal height gain in boys, so final height is more in boys. Okay, so here you can see this is left the axis, y-axis is height velocity. How much is the height velocity? Infancy height velocity വളരെ കൂടുതലാണ് at birth. At birth ഭയങ്കര height, that is child, the gain in height is very high by in the first year, and then it comes down in childhood and in the pre-adolescent period. After that, there's a spurt in adolescence. Okay, then genetic factors, chromosomal diseases like Down syndrome, Klinefelter syndrome, all of them are associated with certain particularities. Like Down syndrome, Turner syndrome is associated with short stature. In Klinefelter, there is tall stature. So Down syndrome, what happens in Down syndrome? Anybody?
Shock gene.
What? I can't hear you.
Gene mutation results in short.
Gene mutation ആണോ chromosome ന്റെ എന്തെങ്കിലും ആണോ?
Trisomy.
Chromosome.
Trisomy 21 ആണ് most common cause for Down syndrome. 95% of Down syndrome is because of trisomy 21. So what is the difference when we mentioning chromosome defect and gene mutation? അത് രണ്ടും രണ്ടാണ്. You know, genes are very, very, very small things. Chromosomes we have only 20. We have only how many? 46 chromosomes. Of adinagatha increase number increase or decrease, all that will make a lot of problems. One of those is trisomy 21, where there is a extra copy of chromosome 21. So that is Down syndrome. Again, gene mutation diseases with gene mutation like Prader-Willi syndrome. I'm sure we've learned about Prader-Willi also. It is one of the examples for Prader-Willi. എന്തായിട്ടാ പഠിച്ചേക്കുന്നത്? Prader-Willi and Angelman.
Genomic imprint.
Very good. Genomic imprinting. So again, Noonan syndrome is one of the Noonan syndrome again can be a genetic this thing, or it can be a chromosomal defect. Random vara. And Marfan syndrome again presents with tall stature. So just to know that genetic when there is a chromosomal disorder or a gene mutation, there can be a set of problems. One of those could be affecting the height, short stature or tall stature. Nutrition is one of very important factors, especially in our country. Keralathil athre illengilum in the less fortunate states in our country, nutrition is the major factor which affects the growth of the child. So PEM nu pannal protein energy malnutrition, that is the malnutrition in both protein and calories. So that is we've learned that nutrients can be divided as major and minor. That is large quantity, what we consume in large quantity like calories, carbohydrates, proteins, fats, all major ആയിട്ട് പഠിക്കുന്നു. And we have micronutrients. Micronutrients are iron, iodine, calcium, zinc, vitamins like A, D. All these can also affect the growth of the child. Infections can be acute infections like diarrhea, or recurrent infections like a recurrent respiratory tract infection, or a chronic infection like a tuberculosis or HIV, malaria, Kala-Azar, chronic giardiasis, chronic worm infestation. All these can affect growth. So it can be infections, and can be toxins like food, from food, or in environment like lead. All these can affect the growth of the child. Okay, so postnatal nammal endakku parnu. First one we said based on the gender, then it can be genetic factors, environmental factors, then hormonal factors. So growth hormone deficiency, I told you, antenatal growth il adinu velya role illa, but in postnatal growth hormone is one of the most important hormones. Hypothyroidism, so thyroid hormone has importance in both antenatal as well as postnatal growth. And sometimes there can be a growth hormone resistance. So growth hormone deficiency alla, there is an endogenous resistance to growth hormone, because of which the body is not responding, there is no adequate growth. Social factors, again, one of the important things in our country, low socioeconomic status, because of which the parents are not able to afford to give a nutrient rich diet to the child. So poor diet, or again infections could be because of that. Hot and humid climate, poor emotional support in case of broken families, orphans. Cultural factors or like religious taboos, because of which they might be avoiding some kind of foods, like protein കുറവായിരിക്കാം. And low parental education, in which case again they are not aware of what they should be giving the child, or what should not be done and what should be done. Okay, so so that is about the factors of growth. This could be a question as such, factors of growth. And this is also so that when you're asking history also, when you have a child who's not growing, you have to find out which of the causes is affecting the child's growth. So divided as prenatal, postnatal. Prenatal, not again, there is maternal factor, fetal factor, placental factor, and similarly postnatal. I will just proceed to the next. Then next is, what are the laws of growth? There are a few laws of growth. First law is that growth is a continuous and an orderly process. That is, I told you, growth is something that starts as soon as the embryo is conceived, and it is a continuous orderly process. But the rate of growth is not uniform. You can see, like we had a look at that slide previously, maximum rate of growth there in infancy, pinne adu kazhiyumbo puberty ilana growth spurt ullathu. So there are periods of acceleration, deceleration, and steadiness. So that is the first law. Growth is a continuous and orderly process, and the growth rate is not uniform. So acceleration in the first half of gestation and the first year of life, after that in puberty. And after second year, there is a deceleration, and then there is a steady period between 6 to 9 years. And in each phase, there are different things that affect growth. In infancy, it is mainly nutrition, growth hormone, thyroxine. And childhood, our hormones are only in puberty, the sex steroids have a role to play. Second role is, growth pattern of every individual is unique, but it always proceeds in these two things: cephalocaudal, that is head to foot; cephalocaudal, distal to proximal. Distal to proximal is the fingers grow before the hand, that is what we meant. So those two things, cephalocaudal and distal to proximal. Third law, different tissues of the body grow at different rates. So just look at this picture. Okay, so just follow my pointer. You can see this is the brain and head, and the x-axis has age in years, and here it is a size attained in percentage of total postnatal growth. So when we are mentioning about different tissues, നമ്മൾ 4 കാര്യങ്ങളാണ് നോക്കുക. One is the general growth, that is a weight gain ഒക്കെ വെച്ചിട്ട്. Then brain growth, then lymphoid tissue growth, and reproductive growth. Okay. So first is general growth. General growth is having an S-shaped curve. So നമ്മൾ പറഞ്ഞു, first year child is growing rapidly, പിന്നെ plateau ചെയ്യും, and then after that puberty strike ചെയ്യുമ്പോൾ there is a growth spurt. So it is a sigmoid curve. That is general growth. Then what happens to brain growth? Brain growth is maximum in the first 2 or 3 years of life, and 90% of brain growth is achieved actually even before this. Okay, 100 ആണ്. 90% ഒരു 3 years ഒക്കെ ആകുമ്പോൾ, 2 to 3 years ആകുമ്പോഴത്തേക്കും 90% of brain growth is attained. So what is the significance? ആ പീരിയഡിൽ any insult can cause long-term damages, developmental delay എല്ലാം cause ചെയ്യാം. Okay, so that is about brain growth. Third is lymphoid tissue. So lymphoid tissue, there is a growth initially itself. The growth spurt is usually in this middle childhood years, 6 to 10 years ilakkeയാണ് ഏറ്റവും maximum ആയിട്ട് lymphoid tissue grow ചെയ്യുക. So what are the lymphoid tissues that we usually see? Again, lymph node അല്ലാതെ വേറെ എന്ത് lymphoid tissues ആണ് നമുക്ക് കാണാൻ പറ്റുന്നത്? Anybody? Throat ൽ നോക്കിയാ?
Tonsils.
Yeah. So tonsils, പിന്നെ എന്തെങ്കിലും ഉണ്ടോ? Adenoid tissue, അങ്ങനെ പലയിടത്തുമുള്ള lymphoid tissues. Tonsillitis, adenoiditis എല്ലാം വരുന്നത് ആ ഒരു ഏജ് ഗ്രൂപ്പിൽ. ആ സമയത്താണ് ഏറ്റവും കൂടുതലായിട്ട് lymphoid tissue proliferate ചെയ്തിട്ടുണ്ടാവുക. And then actually the lymphoid tissue growth comes down. Okay. Reproductive, you can see this is a period of no growth until the child reaches puberty, there is almost no growth in the no change in the reproductive growth, and so hope this is so we what are the laws of growth? One, it is a continuous and orderly process. Different issues where it is there are periods of acceleration, deceleration, and steady growth. Then different tissues grow at different rates, and growth always proceeds in a cephalocaudal and distal to proximal manner. Are we clear till now? Anybody has any doubts? So what would, till now we said what is growth, what are the factors affecting growth, prenatal, postnatal, and what are the laws of growth. Okay. So now we'll go on to how do we measure growth, or how do we say what are the parameters by which we say the child's growth is normal or abnormal. What are the parameters of growth? Okay, I don't know if can all of you guess what are the parameters that you would be measuring? Lakshmi?
Ma'am, height,
Yeah, then
weight,
yeah,
head circumference,
very good.
then abdomen.
അത് മതി മതി വേറെ എന്തെങ്കിലും ഉണ്ടോ പറഞ്ഞോ.
Abdominal circumference.
അബ്ഡോമിനൽ സർക്കംഫറൻസിന് ഗ്രോത്തിൽ വലിയ റോളില്ല. നമ്മൾ പ്രീനേറ്റലി അമ്മമാർക്ക് നോക്കാറുണ്ട്. പിന്നെ വെൻ യൂഷ്വലി നമ്മൾ അസൈറ്റിസ് ഒക്കെ ഉള്ളപ്പോഴാണ് അബ്ഡോമിനൽ സർക്കംഫറൻസ് നോക്കുക. ചെസ്റ്റ് സർക്കംഫറൻസ് ഇസ് വൺ ഓഫ് ദി തിങ്സ് ദാറ്റ് യു മെഷർ. ദെൻ ഹൈറ്റിനെ പിന്നെയും കൂടുതൽ നമ്മൾ അപ്പർ സെഗ്മെന്റ് ലോവർ സെഗ്മെന്റ് റേഷ്യോ എന്നൊക്കെ പറഞ്ഞ് ഡിവൈഡ് ചെയ്ത് നോക്കും. സോ ഫസ്റ്റ്, സോ വാട്ട് ആർ ദ പാരാമീറ്റേഴ്സ്? ഫസ്റ്റ് ഇസ് വെയിറ്റ്, then length or height, then head circumference, chest circumference, upper segment, lower segment ratio, and arm span. Okay, I'll just tell you what each of these are. What is weight ne kuriche aarkum koodal parnu theranda. Why, what is length and height? What is the difference? Anybody? Guess. സമയം കളയണ്ട, പെട്ടെന്ന് guess ചെയ്യ്. Jeshwa. Gayatri.
Ma'am,
Yeah.
can I? Okay,
Yeah.
length when the child is recumbent, and height is when the child is standing up.
Very good. So why do we differentiate between the both? Basically, you know that generally how do you measure height? You make the patient stand and measure the height. So that cannot be done in a baby who cannot stand, obviously. So that is called the length, because it is a horizontal measurement rather than a vertical measurement. നമ്മൾ മാത്സിൽ പഠിച്ചപ്പോൾ നമുക്കറിയാം ഹൊറിസോണ്ടൽ ആയിട്ട് നമ്മൾ ലെങ്ത്തും ബ്രെഡ്ത്ത് എന്നും പറയും, vertical ആയിട്ടാണ് നമ്മൾ ഹൈറ്റ് എന്ന് പറയുന്നത്. So unless you can measure the vertical, you don't call it height. But there is a difference between length and height. Okay, so that is, if you measure length and height for me, it won't be the same. So this is homework for you. One of you, Abhirami has my number. So whoever, somebody who's Enthu can find out the difference and message me the answer by tomorrow. Question is, is the length and height for the same for a person? So same person, same. If it is not, which is more, and what is the difference? Okay, so then you have the head circumference and the chest circumference. That is, it is just a circumferential measurement. I will just go on to that. There is something called the upper segment, lower segment ratio. That is something you measure after you measure your height. Height നോക്കി കഴിഞ്ഞിട്ട് lower segment എന്ന് പറഞ്ഞാൽ it is the it is a distance from the pubic symphysis to the ground. That is the lower segment ratio. and you measure your upper segment by subtracting the lower segment ratio from the height. Arm span, you can see my audio. This is the arm span. This is the arm span. I'm not sure. I'm not able to show properly, I think. So this height from, if you ask the patient to extend his hands both sides and measure from one tip of the middle finger on one side to the other side, that is called the arm span. That is also useful in assessing when there is a problem with the height. Okay, so how do you measure weight? We all know that we use bathroom balances, which are not very accurate. Now we have electronic weighing machines. In a newborn or a small baby, we cannot use who cannot stand. We cannot use a normal weighing balances. Then we have these weighing balances. Okay, so this is not an electronic weighing balance. This is an electronic electronic infant weighing machine. Measurement of length or height. Like we said, length is measured in the recumbent position in babies. So this is, can somebody guess what this is called? It is an infantometer. Okay. So this is used to measure the length of a baby. So this is 0, and this is you can extend this further till 100. So you put the baby's head at this point and make the baby in the midline. Put the baby in the midline and extend both feet. This we push out baby feet measurement you take off baby and you can see what is the length of the baby by using this measurement. So that is called an infantometer. In bigger children who can stand, when you can measure height, you have this thing. This is called a stadiometer. Again, there are some things that you have to make sure of when you are measuring the height. Weight it should be minimal clothing when you're measuring the weight of the child. In adults, it does not matter so much. When you have small babies, the diaper itself will, if it's a heavy diaper full of urine and all that, that itself will change the weight. So you ask the mother to take off the diaper and just wear minimum clothes when you're measuring the weight. Again, when you're measuring height, ask them to remove the slippers. And they should be standing in such a way that you can see how the child is standing. The heel, the buttocks, the scapula boundaries, and the occiput should be touching this line, the stadiometer rod. And you bring down this thing to the height of the child. And the head should be kept in such a way that the Frankfurt plane is perpendicular to this plane. Frankfurt plane, it is a line passing through the lower border of the orbit and through the external artery meatus. Line line should be parallel to the ground or perpendicular to this vertical rod. Okay, position Frankfurt plane and that is how you measure height. We will teach you this again. Just again, head circumference. Head circumference you should measure using a non-stretchable tape, and you should use an overlapping technique. Overlapping technique is point 0 measure minus more accurate. So those are the 3 things you measure. Lower segment ratio perpendicular drop that will give you the lower segment, and then upper segment in height in the lower segment minus any doubts? Doubts
Madam, mid-arm circumference.
Mid-arm circumference. Mid-arm circumference I mentioned. Mid-arm circumference, it is a very important index of growth. Again, mid-arm circumference, how do you measure? It is measured. Yeah, tell me.
Shakir's tape.
Shakir's tape mid-arm circumference or measurement you can use a non-stretchable tape only. Shakir's tape is one of those things that are used in the in community based settings. അതായത് ഷഗിൽ സ്റ്റേപ്പ് വെച്ച് നമുക്ക് നോ മാൽന്യൂട്രീഷൻ ആണോ മാൽന്യൂട്രീഷൻ ഉണ്ടോ ഇല്ലയോ എന്ന് അറിയാൻ വേണ്ടി കുറച്ചുകൂടി ഈസിയർ ആയിട്ട് മെഷർ ചെയ്യാനാണ് ഷഗിൽ സ്റ്റേപ്പ് യൂസ് ചെയ്യുന്നത്. അതായത് അതിനകത്ത് നമുക്ക് കട്ട് ഓഫ് ആയിട്ട് ആ സെറ്റിൽ നമുക്ക് ആക്ച്വൽ മെഷർമെന്റ് തന്നെ എടുത്തിട്ട് വി ക്യാൻ ഫൈൻഡ് ഔട്ട് വെദർ there is a problem or not. അപ്പം mid-arm circumference is measured in the left arm. ലെഫ്റ്റ് സൈഡിലാണ് എപ്പോഴും മെഷർ ചെയ്യേണ്ടത്. ആൻഡ് ഇറ്റ് ഷുഡ് ബി മെഷർഡ് in children from 6 months to 5 years of age. And it is an age independent anthropometric index. That means 6 months നും 5 years നും ഇടയ്ക്കുള്ള ഒരു കുട്ടിക്ക് നമുക്ക് ഒരു കട്ട് ഓഫ് വെച്ചിട്ട് ദാറ്റ് ഇസ് നമ്മൾ ലെസ് ദാൻ 13 കുറവായിട്ട് എടുക്കുന്നു. അപ്പൊ ദാറ്റ് ഇസ് ടേക്കൺ ആസ് ലോ ഇൻ എ 1-year-old child or in a 3-year-old child. മനസ്സിലായോ ഞാൻ പറഞ്ഞത്? അതായത് പൊതുവെ when you are measuring weight, you need to know the age of the child to see if that weight is normal or not. നമ്മൾ പറയുമ്പോൾ അല്ലെങ്കിൽ I just explain as we go along. Okay, so mid upper arm circumference measure ചെയ്യുന്നത് ലെഫ്റ്റ് ആമിലാണ്. You should remember to expose, and ഇവിടുത്തെ you find the acromion and the olecranon and you use a non-stretchable tape. Find the midpoint. അവിടുത്തെ circumference ആണ് measure ചെയ്യുക, mid upper arm circumference എന്ന് പറഞ്ഞാൽ. Okay, so what are the normal average growth parameters at birth in a term baby with no other issues? Usually average weight is 3 kg, length is 50 cm, head circumference is 35 cm, and upper segment lower segment ratio is 1.7. Weight usually will double by 5 months and triples by 1 year. So 3 years at birth, 3 kg at birth, 1 year ആവുമ്പോഴത്തേക്കും average weight usually 9 kg ആണ്. This is എല്ലാം നിങ്ങൾ ഓർത്തിരിക്കില്ല. So how do you know what is the expected weight for a child of for any child? അപ്പം this formula can be used. Just take a screenshot, or I don't know if you have get the recording, then that is fine. This is like something that you'll be applying once you come to pediatrics and you start checking weight for a child. So depending on the age, 3 months to 12 months ulla baby aanengil age in months 9 months aanengil 9 plus 9/2 aanu expected weight. 1 to 6 years le 2x plus 8, 2 into age in years plus 8. 7 to 12 years le 7x minus 5/2. This is known as Veach's formula. ഇത് പിന്നെ നിങ്ങളെ പഠിപ്പിക്കും, ഞാൻ പറഞ്ഞേ ഉള്ളൂ. Okay, so again, increment in height, this you cannot learn by heart. This for you to know. ആദ്യത്തെ 3 months very large increments ആണ്. 3.5 cm per month ഉണ്ട്. അത് കഴിയുമ്പോൾ 2 ആവും, 1.5 ആവും, 1.2 ആവും. And പിന്നെ 3 to 10 years it is usually 5 to 6 cm per year. Height in ഉള്ള Veach's formula is age in years into 6 plus 77. 6x plus 77. Upper segment lower segment ratio. So at birth upper segment lower segment ratio very high ആണ്. അതായത് upper segment is much longer than lower segment. അത് it starts coming down with age, and in adults it is 0.9. By 10 years it almost becomes adult. Head circumference, I told you at birth 35 centimeter ആണ്. And we learned that 90% of brain growth ആദ്യത്തെ 2 വർഷത്തിലാണ് ഉണ്ടാവുന്നത്. അപ്പം large increments of head circumference increase ഈ സമയത്ത് ഉണ്ടാവും. So at first 3 months ഓരോ മാസത്തിലും 2 centimeter വെച്ച് കൂടും. Next 3 months 1 centimeter വെച്ച് കൂടും. പിന്നെ 0.5 centimeters, that is 6 centimeter in the first 3 months, then 3 centimeter in the next 3 months, then again another 3 centimeter in the next 6 months. Okay. At birth, chest circumference will be less than head circumference. Normally, growth aanengil head circumference will be equal to chest circumference by 1 year of age, and after 1 year, chest circumference will be more than head circumference. Okay, ഞാൻ ഒന്നും കൂടെ ഇത് പറയാം. So we said weight, height, head circumference, height in the code, upper segment, lower segment ratio, and mid-upper arm circumference are the main parameters that we measure. Weight is usually measured using an electronic weight machine. When you measure the weight, you have to make sure the child is minimally clothed. Okay, and then when you're measuring, once you've measured weight, you have to find out if what is the expected weight to know if this is normal or not. That I told you about Veach's formula for each age. Okay, then normal, an average newborn is, what is the normal weight?
2.8 kg.
Average 2.8, no, 3 kg, around 3 kg, and it triples by 1 year of age. And in the first weight usually doubles by 5 months and triples by 1 year of age. If you want to know what is the normal weight for a 6-month-old baby, you can use the Veach's formula. That is x plus 9 by 2, whereas x, where x is age in months. Again, height or length in the guide, after 2 years you measure the length. What do we use to measure the length?
Infantometer.
Infantometer, very good. And after 2 years, you can make the child stand, then you can use a stadiometer. I told you what are the things that you should make sure when you are using a stadiometer. What are all those points should be touching the wall or should be touching the rod of the stadiometer. The head should be kept in Frankfurt plane. And once you measure the height, you have to know if it is normal or not. Then you can use the 66 plus 77 formula, which is the expected height. Okay, then again I told you at birth height length is usually 50 centimeter and maximum increment 1 year increment, and 1 year usually length 75 centimeters. Okay, kore numbers just introduction. Head circumference in the what did I tell you? You have to measure the head circumference by using a non-stretchable tape, and it should be measured using overlapping technique. Growth and head circumference at birth is average is 35 centimeter, 33 to 35 centimeter, 35 centimeter, and first 3 months 6 centimeter kodum, next 3 months another 3 centimeter increases, and in the 6 months to 12 months 3 centimeter again increases, so that there is an increment of 12 centimeter in the first year of life. And 90% of head growth is complete by 2 years. Head circumference, usually we don't have a formula as such, because by 2 years, after 2 years, we are not expecting much of an increment. So by using this thing that you have the birth head circumference, you can add how much ever, like 3 months old baby, and you add 6 centimeter and see if the increment is that there is adequate head growth. Okay, then another thing we said, mid-upper arm circumference. So I was telling you, mid-upper arm circumference is an age-independent marker. So all those things that we talked about till now, you must have noticed that how do you know what is appropriate or what is the expected weight or height? You have to know the age of the child. When you are in a setting, in a community setting, where there is it may be in an area where their parents do not really know when the baby was, which is the date of birth of the baby, they don't know how old the child is accurately, you cannot use these measurements to see if their height and weight is normal. Okay, so in those conditions, mid-upper arm circumference is a good index, because mid-upper arm circumference does not change much from between 1 and 5 years in a normal child itself. Okay, 1 and 5 mid-upper arm circumference almost normal, almost same ആണ്. So 1 and 5 ഇടയ്ക്കുള്ള ഏതൊരു കുട്ടിക്കും നമ്മൾ mid-upper arm circumference measure ചെയ്ത് കഴിഞ്ഞാൽ ആ വാല്യൂ വെച്ചിട്ട് you can say if there is malnutrition or there is no malnutrition. Clear ആയോ ആ കാര്യം? Anybody please respond?
Yes, ma'am.
Okay, clear ആണോ? മനസ്സിലായോ ഞാൻ പറഞ്ഞത്? ഒന്നുകൂടെ റിപ്പീറ്റ് ചെയ്യണോ?
മനസ്സിലായി, ma'am.
Okay. So again, head circumference and chest circumference തമ്മിൽ എന്താണ് വ്യത്യാസം? Chest circumference is less than head circumference at birth. becomes equal by 1 year, and after 1 year, chest circumference will be more than head circumference. Postnatal growth, again about arm span and a lot of things. You will anyway learn all this as we go along. Okay, so once we are almost reaching the end of the class. So I told you we measure the weight, height, all those things, and how do you know if it is normal or not? Use the we can use formulas to see what is the expected weight or height, and you can see compare that, and or you can use what are called growth charts. So just about what are the growth parameters to be monitored. In 0 to 2 years, weight, length, head circumference at birth, and then whenever the child comes in for immunization. After 2 years, head circumference very important. Height and weight 6 monthly nokanam. And after 9 years, every year. And you have to look at the BMI also after 2 years of age. Okay, so this is a growth chart. Okay, so this is one way of finding out whether the growth of the child is normal. So ഞാൻ നേരത്തെ പറഞ്ഞ formula വെച്ച് calculate ചെയ്യുന്നില്ലെങ്കിൽ this is actually better than that. Okay, so what is a growth chart? A growth chart is a pictorial representation of the normal growth pattern anticipated. So this is this has, you can see 2 to 18 year boys. Stature for height, that is height for age, stature for age, height for age, and weight for age. Okay, so e growth chart, if you know the age of the child, you can plot the height. The height will be here. The height and weight of the child, and see if it is normal. So there are percentiles. So I hope you are familiar with centiles. എന്താണ് centiles എന്ന് അറിയാമോ?
Yes, ma'am.
Yeah, നമ്മൾ മാത്സിൽ പഠിച്ചിട്ടുള്ളതാണ്. അതിന്റെ ആപ്ലിക്കേഷൻ ആണ്. അതായത് ഫസ്റ്റ് സെന്റൈൽ ഉണ്ട്. അതായത് when you have 100 children, you make them stand in a ascending or descending order, and the first child is the first centile. അപ്പോൾ this is the growth charts are developed after taking the heights, weights of large number of normal children to find out what is normal. So once you have the height and weight of the child, you can plot it, and if it is below the third centile for height or weight, it is taken as abnormal. Again, when you come for your practical classes, we will show you how to use growth charts. So age will be along the x-axis, measurement, that is height or weight, will be along the y-axis, and you have percentile curves. Blue is for boys and pink is for girls. So here you can see a plotted 8-year-old boy, height 120 centimeter. You plot the 120 centimeter. 120 centimeter. Height draw. Okay, that question. Just see. 120 centimeter. 120 centimeter 8 years. And you can plot the height of the child and see if it is normal or not. So this is the WHO growth chart, and this is the IAP growth chart. We have both growth charts, which both can be used. Sorry. WHO growth charts are actually developed from multiple countries. It is a multi-center growth reference study from including India, 6 countries from where there are different types of people, like US with a very higher index, and poorer countries are also included, and so that is assumed as something that can be applicable universally. And it is derived from children raised under optimal conditions for growth, like exclusive breastfeeding, healthy environment, etc. Okay. So that is it for today. So today we discussed about what is growth, what are the factors determining growth, what are the laws of growth, what are the things that you assess in growth, and what are the once you've assessed growth, how assess the parameters, what do you do to say if it is normal or abnormal? Okay, anybody has any doubts? You have, yeah, I think 1 or 2 more minutes only. Anybody wants to give any comment? Was it clear? Basil? Basil, can you unmute?
Yes, ma'am.
I told you about prenatal factors affecting growth. Which are the hormones involved in growth in the prenatal period? Anybody?
Insulin, thyroxine for differentiation of tissues. Then glucocorticoids for maturation of lungs, liver, and GIT.
Who is this?
Ma'am, Lakshmi.
Okay. Which hormone is not involved in prenatal growth, Lakshmi?
Growth hormone. Growth hormone.
Okay, very good. Okay. Okay, so I think we can stop. Please feel free to message if you have any more doubts or anything. Okay. Shajit sir, leave it on meeting.
Leave it on.
Okay. Okay, thank you everyone.
Thank you, ma'am.
Hello? Doctor. Hello?
Hello, sir.
Can you hear me?
Yes, sir.
Okay, fine. Let's begin.
Yes, sir.
Right. Okay, good afternoon, everybody. So, I'll be talking about 3 small topics today. I may not take much time. 3 things. One is pseudo-arthrosis of the tibia. Second, torticollis. And the third one is arthrogryposis multiplex congenita, which is rightly known as multiple congenital contractures, MCC. That will be a better term for that. As far as you are concerned, the first one, that is the pseudo-arthrosis tibia, may be important. That can come as a short note for you. But as far as the treating orthopedic surgeon is concerned, one thing in common for these 3 conditions are the treatment of all these conditions are very, very difficult. The result is unpredictable, and more often the treatment may be a failure. You may not get the correct response to the treatment for that patient. That is the problem with the orthopedic surgeon, and as far as you are concerned, you may get a short note from pseudo-arthrosis of the tibia. Okay, let's go to the subject. First, congenital pseudo-arthrosis. Pseudo-arthrosis means false joint. So congenital pseudo-arthrosis is a specific type of non-union that is mostly incipient at birth. You may not see it at the time of the birth, but manifests later. The etiology is unknown because a normal bone breaks without any trauma or anything. The etiology is unknown, but it's an end-stage expression of multifactorial factors. Up to 50% to 90%, the one observation is that up to 50% to 90% of patients who are having this congenital pseudo-arthrosis tibia have strong association with features of neurofibromatosis. Hope you are thorough with neurofibromatosis. You should be aware of NF1, NF2, which are autosomal dominant, single chromosome determined diseases, the skin stigmata associated with neurofibromatosis like alveolar spot, axillary fleckling, then leash nodules. All these things, hope you should be knowing. And if you find a patient with pseudo-arthrosis tibia, you should positively look for features suggestive of neurofibromatosis. You may get it. So almost as high, the coincidence is as high as 90%. Then what is etiopathogenesis? The true cause of poor healing potential of the bone is unknown. But one common factor is that at the pathological site, there is haematomatous, thickened fibrous tissue with limited ingrowth of vascular ingrowth is seen at the pathological site. So the bone is replaced by haematomatous fibrous tissue. That is a problem. So also the vascular ingrowth is limited. So when it is injured, the healing is also difficult. So that is the problem. The congenital pseudo-arthrosis is not limited to tibia alone. The common affected bones are tibia and fibula, clavicle, neck of femur, radius, and ulna. And our discussion will be limited to pseudo-arthrosis of the tibia. The commonest clinical presentation will be an anterolateral bowing of the tibia. So in a newborn, when you get an anterolateral bowing of the tibia, as you see in this picture, you should first suspect pseudo-arthrosis of the tibia. Similarly, seemingly dangerous situation is posteromedial bowing, both to the onlookers, parents, but the prognosis is entirely different. Posteromedial bowing is relatively benign condition which gets corrected by itself. But if it is anterolateral bowing, it is almost always pathological, and you have to think about the most commonest cause, that is pseudo-arthrosis of the tibia. Basically, pseudo-arthrosis tibia can be of three types. That is dysplastic. That is the commonest variety where pseudo-arthrosis occurs over a sclerotic tibia. Then the other one is the cystic variety. That is the pseudo-arthrosis develops along a cystic lesion at that region. And the late onset where relatively older age children are affected, fracture occurs with minimal trauma and fails to unite. So these are the basic three types of pseudo-arthrosis tibia that you find clinically. Then, now you know the clinical aspect, then let's go to the classification. There are a lot of classifications for pseudo-arthrosis of the tibia, like Crawford, Boyd, etc. Ideally, a good classification should help you understanding the severity of the disease. As you ascend the degree, the severity should also increase. It should help planning the treatment and should have prognostic significance. But unfortunately, none of the classifications suggested for pseudo-arthrosis of tibia has but it helps you to describe the patient's problem in a organized manner. And most importantly, this helps you to pass the examination. Very easy to remember. So let's see what is Boyd's classification. This is the most accepted one. Boyd divided into 6 types radiologically. The type 1, there is just anterior bowing along with the defect of the tibia which is present at birth. And it is usually associated with other congenital anomalies as well. And most of the time, the management is dependent much upon the coexistent other congenital deformities. Then type 2, this is the commonest one and perhaps the most difficult one to treat as well. There is the anterior bowing and hourglass contracture, and you can see the hourglass contracture of the tibia, and there will be tapering of the edges. It will be rounded off and sclerotic, and the fracture will occur in that region. There will be obliteration of the marrow cavity. This tibia is called the Hyrus Tibia, and fracture, usually spontaneous fracture without much trauma, occurs before 2 years of age. This is the commonest variety. In type 3, develops in a cystic region. There may be a congenital cyst and a weakened area, and there will be associated anterior bowing, and it fractures. It has got a relatively better prognosis among all the 6. Type 4, again, this is a sclerotic variety, but there is no narrowing of the tibia. A stress fracture develops. You can see that here it is beginning to happen. Here it is beginning to happen. And when it is complete, that produces a fracture and it will be treated as type 2. Type 5, there will be associated dysplastic fibula also. Here, fibula is involved. Usually, fibula is the first one which is involved. After that, the tibia is getting affected. If that happens, again, the prognosis as that of the type 2. And type 6, the fracture develops in an intravenosus schwannoma or a neurofibroma. So this is all about the Boyd's classification. Easy to remember. I think the X-rays are very clear, and that will fetch you 3 or 4 months. The treatment, as I told you in the beginning, the treatment is the most difficult part and what makes this condition very much important in the modern orthopedics. It's a problem that is very difficult to treat with high rate of failures, demanding multiple surgeries, and many often ends up in amputation. When you hear amputation, don't think that it's a bad surgery, about which, the need of which, the good result after amputation we will discuss. Okay, now coming back to the treatment without amputation. What are the principles of treatment? That depends upon the age of the patient and the presence of a fracture or not. When there is a presence of a fracture, the treatment changes entirely. before the fracture occurs, if it's a child where bone maturity has not occurred, you can treat him conservatively by external splinting so that the limb is protected and fracture will not produce. And you have to protect the limb till bony maturity. The reason being that in an adult child, or as the patient approaches bony maturity, the chances of a successful surgical outcome is more. So you have to protect the limb till then. So in a child, the chances of success of surgery increases with age till bone maturity. So if not fractured, external bracing will help you to prevent fracture and protected weight bearing advised till bony maturity. Once fracture has occurred, irrespective of the age, there is no role for any conservative management. I told you the fracture occurs through a pathological tissue, which is not going to unite at all. So the first and foremost thing, the aim of the surgery, as you know, it is a bent tibia. So the aim of the surgery is to maintain the axial alignment. Then an intramedullary fixation is preferred. Why intramedullary fixation is because this is notorious for refracture. So once the implant is there, that gives some stability and it prevents the deformity as well, reappearance of the deformity as well. Then why nail? Because it's a load sharing device. That means once you put a nail inside the cavity, the forces that is passing through the bone is partially shared between the implant as well as the bone, so that the normal physiology of the bone is maintained. While in plate, that is not so. So an intramedullary fixation is preferred to plates. So also you have to maintain the axial alignment. But most importantly, if you want to get the union, you have to excise the pathological tissue, because the fracture occurs through the fibrous tissue, not to the bone. So that is a problem here. So you have to remove it. So naturally, once you excise the pathological tissue, naturally there will be a gap. So following this procedure, other procedures to address the bone loss along with other bone healing augmentation procedures also will have to be done. Let's see what we can do. So how to address the bone defect? One, you can primarily shorten the limb. After excising, you oppose both the ends together, then do an IM fixation, accept the shortening for the time being, and you use autologous bone grafts. So bone grafting is a very good short note for you. You can read about that. So you can use autologous bone graft, primary shortening, IM fixation, and autologous bone graft. And after that, you can compensate for the shortening either with a shoe raise if it is up to 2 inches, or more than that, you can go for a limb lengthening procedures at a later time. So that is one procedure. Second, if the defect is more, then you will have to do with the vascularized tubular graft. I shall show you the pictures later at the next slides. And the second one is the Ilisaro's limb reconstruction. The first modality, that is the primary shortening, IM fixation, and autologous bone graft, has met with many failures in the history, in the past. And so people are more and more moving towards vascularized tubular graft. And the success rate was as high as 60 to 95% depending upon various series. But unfortunately, the problem here is that the fibula is a relatively thin bone, and the chances of refracture was more till the tibula, the vascularized fibula is taken very well, graft is taken up, as well as the fibula is hypertrophied by loading. Till then, it has to be protected. So that bad result can be overcome by using Ilisaro's limb reconstructive procedure. Here, the advantage is that the chance of reconstruction, chances of refracture is less, which has similar success rate as that of the vascularized fibula. So this is the first one that they have done. Here you can see that the fibula is fractured. This much of tissue was removed. That was opposed primarily that was supposed the defect was closed and an intramedullary rod was applied. You can see that there is a deformity here, and that is why they have purposefully bypassed the angle to prevent the deformity of the angle joint. And this rod is a telescoping rod. You can see that the diameter here is more, here it is less. It's a telescoping rod that allows for lengthening of the implant along with the growth of the patient. And this is one modality of management. If everything is going fine, okay, fine, no problem. But I told you the success rate was very low, and hence we thought about other procedures. You can see that here, this is the gap, this much of gap is there, and you can see that there is a small piece of fibula, that is vascularized fibular graft was applied. And these are ring fixators, of course, Ilisaro fixators, but they are now used as just external fixators to maintain the gap and give stability to the bone. And this is the final good result where the fibula has taken up. And this is the Ilisaro's reconstructive method. Here you can see that this was the actual gap, and this is the transport. Bone transport is done using the Ilisaro, and this much length has been transported. And once you turn the nuts and once you turn the nuts here and bring this ring downwards, along with that, this bone also will go down and the new bone will be formed here. Because we have done the corticotomy at this side, which is a normal bone, and by transporting the bone within physiological limit will produce new bone formation here. The increase in vascularity following a corticotomy and new bone formation will enhance healing in this region as well. So these are the three methods by which you can tackle the bone loss after excision of the pathological tissue. And then, of course, there are bone healing augmentation procedures, especially this is used once you do the first procedure, that is intramedullary fixation along with the intramedullary fixation, excisional intramedullary fixation, and primary fixation. In that condition, definitely you have to add bone healing augmentation procedure. The time-tested one is the bone grafting, and the others that was being tried was BMP 2 and 7, bone morphogenic proteins. It can be a short note for you, BMP. Then the electric stickle stimulation along with can be given after by introducing an electrode there. You can do a electrical stimulation. So these are the bone healing augmentation procedures. Then amputation. When you hear about amputation, you think it's a mutilating surgery, but amputation is not that mutilating, especially if it is below knee amputation. I told you this is a surgery. This is a treatment where you will have to go for multiple surgical procedures. The child has to go for the ordeal of multiple surgeries, and at the end of the day, if he gets a small limb, short limb, deformed limb, chances of refracture, and he is walking with a limping gait, instead of that, if you do an amputation and give him a BK prosthesis, the new generation processes will help you to walk as normally as possible. You may be knowing the story of Pistorius and all, who competed even in Olympics. So amputation is not a bad surgery, but here we may be forced to do the amputation irrespective of our will, and the absolute indication being multiple failed surgical interventions. When already 2 or 3 surgeries have been done, don't think that I can heroically heal that bone, because each and every surgery, the surgeon will be stripping the periosteum, and remember, the most perfectly performed surgery is an insult to the injury. So you will be injuring the soft tissue, precious soft tissue envelope, and here already you have damaged the already compromised soft tissue already here. So you are also likely to fail. So the absolute indication being multiple failed surgical interventions. Relative indications are shortening more than 2 to 3 inches and stiff and deformed angle joint. Of course, with modern orthopedics, you can definitely correct a shortening of 2 or 3 inches easily, and deformity also can be corrected, but you are doing the surgery in a child. So definitely amputation has a role which has to be done judiciously in consultation with the parents. Sometimes there will be no other option other than amputation, especially when multiple failed surgical. This is a relative indication. Okay, fine. Then what are the complications of pseudo-arthrosis tibia, which we have already mentioned? I think that is the stiffness of the ankle and hindfoot, and refracture and a deformed ankle. This happens especially when the type 5 variety, where there is a dysplastic fibula as well, and there is a shortening. Fine. So our first topic of congenital pseudo-arthrosis of the tibia is over. I was talking about the problems with congenital pseudo-arthrosis tibia is physiopathogenesis. Then the classification that you should know, perhaps that may help you to narrate the X-ray to somebody else. Once you say that type 1 is like that, type 2 is like that, so they will be knowing the history. They can, you can very well reproduce that. Then at the end of the day, they will give you some marks as well. So board's classification you should know. Then the management protocol, I told you, different options. The basic principle is maintenance of the normal axis of the tibia and intramedullary fixation. Why intramedullary fixation? I told you. Then the basic principle is excision of the pathological tissue that will leave behind a large gap or large defect in the tibia. The defect can be managed by 3 ways: primary apposition and intramedullary fixation with bone healing augmentation procedures. Then vascularized tubular duct and Ilisaro's bone reconstructions, which gives much better results. And of course, amputation has a role. So that finishes our first topic. And now let's come to the second topic. So that is torticollis. This is the classical clinical picture of torticollis. The ears are being drawn towards the sternoclavicular joint of the same side, or head is tilted towards the same side and face is turned towards the opposite side. This happens when the sternocleidomastoid is contracted usually. And long-standing posture like that will produce facial asymmetry as well. So this is what is called torticollis. Many a times torticollis is being referred to temporary conditions like simple rhineck and all. So in order to include everything, the torticollis, the causes can be: 1, congenital muscular torticollis. That is the most important one, about which we are going to talk about. The other causes of torticollis include cervical spine abnormalities. The most important one that you see usually in the clinics, the pediatric clinics, is the Atlanto axial subluxation. And this usually following an upper pharyngeal infection. Usually the history is that on waking up from sleep, the child is having a torticollis. That is a complaint of the mother. When you ask the history, they will tell you that there is a recent episode, or at that time also the patient is having an upper respiratory infection. What happens is that an infection means hyperemia, and the persistent hyperemia will lead to softening of the ligaments in and around that region. That is the transverse ligament that holds the odontoid to the atlas will be lax and lead to subluxation of the Atlanto axial joint. And that will lead to temporary subluxation, and that will lead to the torticollis. That is the most common symptom, that the commonest one that you come across in clinical practice, especially in pediatrics. Then, of course, following trauma, you can produce a subluxation or a facetal joint subluxation you can have. Then there is congenital abnormalities of the odontoid as well as the facets can happen. Then facetal subluxation can occur as a following trauma or following non-infective inflammatory conditions like rheumatoid arthritis or ankylosing spondylitis, where the synovial joints are involved. You can have a torticollis. Then one of the common presentation of a spinal tumor due to irritation of the spinal nerves would be torticollis. So these things have to be kept in your mind before jumping upon something as the cause for the torticollis. So late onset torticollis can be due to these things. Then of course other causes, less important causes like GERD, gastroesophageal reflux, then ocular torticollis, then drug-induced dystonia. Anyway, as far as the orthopedician is concerned, we are going to concentrate on the congenital muscular torticollis. This follows what you call the stereomastoid tumor. Hope you know, you have known something about stereomastoid tumor that is very well described in DAS, surgery, Bailey, and all. So we'll have something more. So everything follows a vascular insult to the stereomastoid. Following a vascular insult of the stereomastoid muscle in the intrauterine period or during labor, that can produce a stasis of the blood leading to hematoma and ischemia. That will lead to necrosis of the muscles, and that will produce a swelling of painful, swollen stereomastoid muscle. That is called the stereomastoid tumor. This heals by fibrosis. Fibrosis occurs naturally. The next will be the contracture, and that will lead to a shortened sternocleidomastoid, which is being replaced by fibrotic tissue rather than a resilient muscle fibers. So a contraction of the sternocleidomastoid will turn the head towards the opposite side and tilt the head towards the same side. When you keep it for a long time like that, other muscles on the same side like the scalene, as well as the deep cervical fascia, even the carotid sheath will be contracted, shortened, and the carotid vessel will be smaller in caliber as well. These are the long-standing effects of the keeping that head in that position alone. So this is the etiopathogenesis of congenital stereomastoid tumor. And stereomastoid tumor, as you know, is the first tumor to appear, usually within 2 to 3 weeks. Actually, it is not a tumor, I told you. 2 to 3 weeks after birth, as a tender fusiform swelling on the sternomastoid, it usually disappears in 4 to 6 months. But along with disappearance, there will be a fibrotic cord or a fibrotic nodule in that region. Finally, the affected muscle is replaced by contracted fibrous cord-like tissue. Postural adaptive changes, as we described right now, like contraction of the deep cervical fascia, scalene muscles, and carotid sheath, all these things happen. And what is exactly happening to the muscles? The histopathologic examination of the affected muscle showed that the results are exactly similar to that of changes in the muscles of the forearm muscles that are affected by a compartment syndrome. Hence, it was suggested that stereomastoid tumor is a result of a compartment syndrome affecting the sternocleidomastoid following an assault during the labor or the intrauterine period. This hypothesis is supported by the observation that the stereomastoid tumor is closely associated with conditions like metatarsus adductus, developmental dysplasia of the hip, breech presentation, CTV, and a difficult delivery. You know that all these conditions are what you call the packaging defects. When the uterus is non-resilient, as in a primipara, oligohydramnios, all these conditions are associated with this. So that is this observation also suggests this hypothesis. Then what is the clinical feature? As I told you, as you have seen in that picture, the head is tilted towards the same side and the face is turned towards the opposite side. But there will be associated facial asymmetry. That is the one which separates this from torticollis due to other causes, because this is a congenital one while the others were acquired one. So there will be a painful, tender swelling of the stereomastoid tumor, and later a fibrotic nodule or cord can be palpated. The affected half of the face is hypoplastic. It is shorter from above downwards and wider from side to side. The brow arc is less prominent. The frontal eminence is flattened, and the occipital eminence is more prominent on the affected side. So this will be the clinical features in torticollis. treatment. During the initial period, that is the hematoma period, once it is highly tender and painful, you have to wait till the inflammation is over. Once the painful phase is over, passive sterile stretching physiotherapy can be started. And that may help. Rather than the treatment modality, it is the percentage of involvement that is more important. If less than 35% of the muscle fibers are affected, that will usually respond to conservative stretching therapy. But if it is more than that, it may end up in surgery. What surgery you do? Here the problem is a contracted fibrotic sternocleidomastoid muscle. So you have to remove that, you have to release that contracted structures on the affected side. So that depends upon, so it has got two attachments, as you know, below and above. Below it has got two attachments on the sternal head and the clavicular head. Above it is attached to the mastoid process. So you can release either from unipolar release, either from one side, or bipolar release from both sides, depending upon the amount of release that is needed. Along with that, you may have to release other contracted structures like scalenum muscle as well as deep cervical fascia also. So the treatment is basically, if you can try conservative management. Once the pain is over, try with serial passive stretching. If not getting relieved, you may have to opt for surgery. Surgery can be unipolar release or a bipolar release along with other contracted structures. When will you do the surgery? The timing of the surgery is important. So surgery in an early infancy is not warranted, but correction has to be attained at least before 3 years. Usually the age group that is preferred is 1 to 3 years of age. Why 3 years? Because if it is more than that, you may not get adequate time for the already affected hypoplastic facial components to remodel. So if you want to get more time for remodeling, you have to do it early. So to get enough time for remodeling of the facial asymmetry, it is better to get it done at this age group. And second thing is, you have to get it done before the ocular fixation in brain. Because of our binocular vision fixation, if that doesn't happen, if at all you get the correct, in order to have a better view, the patient will have to assume the position in which the ocular fixation has occurred. So you have to get it done before the ocular fixation as well. Then after 3 years, there will be secondary postural changes of the bone as well as the soft tissues, which will make your job much, much difficult. So that is the timing. I think you are not feeling to do like this because I think I was pretty fast. And I think I'm clear as well because I think I have finished so fast. Should I go slower? Anyway, we'll skip through our last topic. That is Arthrogryposis multiplex congenital. I think there is not of that much important to you, I think, but you can expect a short note at the maximum. But you should know this, a condition like this is there. This is a syndrome complex due to more than 300 different clinical disorders. So the etiology may be different, but at the end of the day, what they produce will be the same. That is, the phenotypic expression of all these conditions is same. That is, multiple joint contractures. So the etiology is different. More than 300 different clinical disorders have been described, but they have a common phenotypic expression of multiple joint contractures. Then other features like absent or less skin creases. You will not see any skin creases here, right? That you see in a doll, right? And loss of subcutaneous tissue as well. Fusiform limb. From here to here to here, it will be the same as if in a doll. That is why it is called doll-like features. Then causes can be, as I told you, there are 300 different causes. The causes can be neurogenic causes, it can be myogenic causes, it can be skeletal causes, there can be environmental factors as well. It is usually as part of well-established syndromes. The orthopedic syndromes we are interested will be Freeman-Sheldon, Larsen syndrome, sacral agenesis, myelomenincocele, spinal muscular. Whatever be the cause, at the end of the day, you will get multiple contractures of the joint. It's otherwise called multiple congenital contractures. That's a better term for that. Even though the child is crippled, their intellect is absolutely normal or perhaps exceptional. And there are basically, they can be divided into two types. That is the classic type involving all the four limbs. As you can see in this picture, here the upper limb is affected. If you look carefully, you can see that the upper limb is internally rotated and kept adducted. The hip is abducted, knee is flexed, and there is clubfoot deformity. So the old and the elbow, there is extension deformity. All the joints are affected here, right? This is the classic type involving all the four limbs. And while this child is less crippled, you can see that she can flex the elbow here. The knee appears to be normal here. And here they have got a flexion contraction of the wrist joint, flexion contraction of the MCP joint, and the foot also seems to be normal here. This is the distal arthrogryposis involving the fixed hand and foot contractures. So these are the two major clinical varieties of arthrogryposis that you can see. As I have shown you in the last picture, the upper limb, the shoulder is internally rotated and adducted. The elbow is usually extended, sometimes flexion contraction, sometimes flexion can be there. Then flexion contraction of the wrist and MCP joint, then extension of the IP joint. In the lower limb, hip is externally rotated and abducted, knee extended or can be flexed. Often knee and hip may be subluxated or dislocated. The hand and foot, in the foot, the deformity will be a clubfoot deformity, the talipes equinovarus, and in the hand, there will be a club hand, radial club hand will be there. While approaching treatment, you should have a realistic approach. You cannot say that I can cure your condition. I can make you as normal as any other child. The aim of management in lower limb is to make him ambulate, whether with the help of a caliper or whether with a limbing or whatever it be. And for the upper limb, the aim is to make the patient able to perform the activity of personal hygiene at least, and if possible, daily living. Remember, whatever you do, recurrence is very, very common. One slide I think I am missing is the pathology. The pathology here is that the muscle fibers are replaced by fibrous tissue along with fatty infiltration. More than that, the structures in and around the soft tissues in and around the joint is highly infiltrated with, especially the capsule, the ligaments, etc., are infiltrated with fibrous tissue, and that produces the deformity in arthrogryposis. The treatment modalities include stretching physiotherapy, surgical release, relocation of joint, muscle transfer, osteotomies to obtain a functional position and to get useful arc of available movements. I will just explain what exactly it is. Stretching physiotherapy, you know that. For example, if there is a flexion of the elbow joint, you can try to stretch it. If it is mild, you may be able to, you may be successful. And surgical release of contractures may be done if your conservative management fails. Then one common finding that you find is a subluxated knee joint, and all for that, you have to relocate the joint, you have to release the contractures, then only you will be able to relocate the joint. Then muscle transfer. Sometimes some muscles may be contracted and their functions can, if it is very important, can be replaced by other muscles which are available but not essential. By muscle transfer procedures, sometimes you can get osteotomies. Suppose the knee is kept in a fixed flexion deformity, the patient is not able to bring the foot back into the ground. And there is a stiffness of the knee joint as well. Then it is very difficult to get the correction done by soft tissue release. Then if you do an osteotomy in the supracondylar region of the femur, you will be able to, extension osteotomy, you will be able to bring the foot back into the ground. So an osteotomy will be an easier option than an extensive soft tissue correction sometimes, right? And at that time, sometimes you may be able to utilize whatever arc of movement that was available, which was not in the functional position, now can be used in the functional position as well. So these are the treatment modalities that you do. To summarize: 1, stretching physiotherapy. Not able to correct it, surgical release can be tried. And any subluxation and dislocation of the hip or knee has to be corrected. Then osteotomies you may have to do sometimes when a surgical soft tissue release alone will not help you to correct the deformity, and osteotomy may help you. And in spite of all these things, the 25% of all patients are non-ambulatory. So that is why I told you, you may not be able to make all these patients as normal as possible. So that is the problem with all these 3 conditions. You cannot say for sure that we can cure this condition. I think I am much earlier, but I have finished it, all the 3 topics. Thank you. I think were I a bit faster?
No, sir.
See any more slide? Was it clear to you?
Yes, sir.
Enough?
Yes, sir.
Okay, fine. Thank you.
Thank you, sir.